Hello, Dr. Menasri. Today, I will review blood pressure measurement in anesthesia and intensive care. So we'll cover physiology, measurement methods, practical precautions, and invasive monitoring. Blood pressure reflects tissue perfusion and organ oxygenation. However, normal blood pressure does not always mean adequate perfusion. Both invasive and non-invasive blood pressure measurements rely on the arterial pulse wave, which travels from the heart to the peripheral arteries and precedes the systolic ejection volume. As we move farther from the heart, systolic pressure increases and the pulse wave becomes narrower because of changes in the diameter and elasticity of the arteries. However, the mean arterial pressure MAP remains constant. The MAP is defined as the average pressure exerted by the blood on the arterial walls throughout a full cardiac cycle. It can be calculated in two ways using these formulas. Diastolic pressure plus 1/3 of the pulse pressure, cardiac output multiplied by peripheral resistance. The pulse pressure is the difference between systolic and diastolic blood pressure. Now let's discuss non-invasive blood pressure measurement. The most commonly used method in the OR and the intensive care is oscillometry. Oscillometry uses a special cuff to detect pressure oscillation during the cardiac cycle. It identifies the mean arterial pressure at the point of maximum oscillation. Systolic and diastolic pressures are then estimated by an algorithm. The second method is the classical Korotkov technique, using a stethoscope. The first sound corresponds to systolic blood pressure, and the disappearance of sounds indicates diastolic blood pressure. The other method is Doppler ultrasound. It works like a stethoscope, using sound waves to detect blood flow. It is very useful in patients with peripheral artery disease, like in ICU and in neonatology. The other technique is photoplethysmography. The photoplethysmography uses a light-emitting diode and a photodetector to measure changes in the volume of blood in the finger during each cardiac cycle. This is the principle behind pulse oximetry. Modern applications include wearable devices like smartwatches, although in medicine, validated monitor remain the standard. The other technique is the arterial tonometry. Is a non-invasive method that measures blood pressure at each pulse by partially compressing an artery against nearby bone. We'll talk about some practical points for cuff measurement. The cuff size can significantly influence readings. Choose a cuff that fits the diameter of the limb, whether arm or leg. A cuff that is too small will overestimate blood pressure, while a cuff that is too large will underestimate it. Avoid placing the cuff on an arm with an IV line. The position of the cuff is at the level of the right atrium. Each centimeter of misalignment equals approximately 0.77 millimeter mercury error. So beyond this classical method, new technologies are emerging. One example is the ClearSight system. It uses a finger cuff sensor based on photoplethysmography and the volume clamp method. This allows continuous, non-invasive blood pressure monitoring beat by beat. Validation studies have shown that ClearSight can measure mean arterial pressure within about 5 millimeter mercury compared with invasive arterial line. That level of accuracy is clinically acceptable and makes the device particularly useful in situations where invasive arterial cannulation is not possible or not desirable. In some situations, we need to switch from non-invasive to invasive blood pressure monitoring. This is typically indicated during major surgery or where there is hemodynamic instability. The technique involves placing an arterial catheter, usually in the radial artery or sometimes in the femoral artery. This method provides continuous, reliable measurements and also allows us to analyze the shape of the pressure waveform. For example, the upstroke slope reflects cardiac contractility. The systolic area under the curve relates to stroke volume. The dichrotic notch position gives information about vascular resistance, and respiratory variation in the waveform can reveal fluid responsiveness. So invasive monitoring does not only give numbers, it also provides rich diagnostic information through waveform analysis. The procedure has three main steps: arterial puncture and placement of the catheter, connection of the catheter to the tubing and pressure transducer, flushing the system to remove any air bubbles. All of this must be done under strict aseptic conditions to reduce the risk of infection. Once connected, we need a proper quality control setup. First, the system is zeroed to atmospheric pressure at the level of the right atrium. Second, we must check the damping coefficient of the system. So damping is important. If the system is under-damped, the waveform will exaggerate systolic pressure. So systolic pressure will be too high, and underestimate diastolic pressure will be too low. If the system is over-damped, the waveform will appear flattened, and both systolic and diastolic values will be misleading. To ensure correct damping, we perform fast flash test. So a normal system shows one clear overshoot oscillation, like shown in the picture. In a properly damped system, the fast flash test produces exactly one overshoot oscillation, as illustrated here. Multiple oscillations equal underdamping, whereas no oscillation at all equals overdamping. So we'll talk about Allen's test and alternative. Before placing a radial artery catheter, the classical approach was to perform the Allen's test to check the collateral circulation of the hand. The principle is simple. First, the hand is emptied of blood by clenching and releasing the fist. Then both the radial and the ulnar arteries are compressed. Finally, the ulnar artery is released, and we observe how quickly the hand regains color. Normal recollection should occur within 5 to 15 seconds. The test is not reliable. Sensitivity is only 60 to 70%, with both false negatives and false positives. Studies shows also there is no reduction in ischemic complication when using this test. That is why recent European recommendations do not advise using the Allen's test as a decision-making tool. Instead, two better alternatives are available. The first is modified pulse oximetry test. A sensor is placed on the thumb while compressing the radial artery. If the signal remains stable, ulnar perfusion is adequate. Doppler ultrasound considered the gold standard because it directly visualizes blood flow and can reveal anatomical abnormalities. According to the new 2024 protocols, Allen's test should be abandoned. The recommended sequence is start with modified pulse oximetry and confirm with Doppler if needed. Like all monitoring techniques, both non-invasive and invasive blood pressure measurement have potential complications. So for non-invasive, repeated inflations can cause nerve compression injuries. They may also produce limb edema, especially in critically ill patients. In invasive, distal ischemia is the most concerning complication. The risk is about 3 times higher when catheters larger than 20 gauge are used. Thrombosis and embolism can occur. Infections are possible. Hematoma at the puncture site are common, but usually minor and self-limited. In summary, non-invasive monitoring is generally safe, but has minor drawbacks. Invasive monitoring provides accuracy and continuous data, but carries risks that require vigilance and good technique. Thank you.